Hello, everybody. Dr. Becker, jumping right into chapter 62. With this PowerPoint, I'm going to do kind of a mix between the PowerPoint for the text from Laney's and then as well as the 2022 Gold Standard COPD guidelines. We're going to kind of mix it up a little bit here. First, talking about asthma. It's a very common condition. You're going to run into people, both adolescent and adults and children, but adolescents and adults for this course, that have asthma. Remember that the characteristic signs and symptoms: breathlessness, tightening of the chest, wheezing, dyspnea, or a cough. That is different than COPD, which often has more of a sputum production component as well. The pathophysiology of asthma is something that Laney's goes through and reviews with you. This is the slide from your book, figure 62.1, and walks us through how this works. So asthma is an inflammatory disorder of the airway. The cause of the airway inflammation oftentimes can be unknown, but there's some kind of trigger or allergen is what we think happens. So the process begins with binding of an allergen molecule. That could be dust mite, that could be something out in the air. And that molecule, that allergen, binds to immunoglobulin E, IgE, the antibodies on the mast cells. So that causes the mast cells to release then the histamine, leukotrienes, interleukins, prostaglandins, etc. And those mediators here have two effects. Immediately, they do cause bronchospasm or bronchoconstriction of them directly. So part of it right away can cause that bronchoconstriction. However, in addition to that, when these are released, they promote the inflammatory cells, eosinophils, leukocytes, and macrophages to be released, and those inflammatory cells then release their own mediators of cytokines, leukotrienes, interleukins, etc., and that is what results in the airway inflammation. Between the inflammation and the bronchoconstriction is where you get limited airflow, which is what that represents here. So we have an allergen. It binds to the IgE antibody on the mast cell. That triggers the release of these mediators. Those themselves here cause a bronchospasm, but then they also cause the release of eosinophils, leukocytes, macrophages, which then causes a release again of cytokines, leukotrienes, interleukins that causes the inflammation. The end result then, of course, is this limited airflow, and that is characterized by edema, mucus plugging, and smooth muscle hypertrophy. And the inflammation state produces a state of bronchial hyperactivity, which is discussed here, which then also perpetuates the bronchoconstriction. Because of this bronchial hyperactivity that results of this, people also then can get triggered by cold air, exercise, tobacco, or other things that perpetuates the cycle of the bronchospasm. That process we just talked about is asthma, that is this immune-mediated airway inflammation, versus when we talk about COPD, which is a chronic, progressive, largely irreversible disorder characterized by airflow restrictions and inflammation. Those signs and symptoms: chronic cough, excessive sputum production, wheezing, dyspnea, and poor exercise tolerance. Cause is mainly cigarette smoking. The symptoms of COPD result from a combination of the two processes of chronic bronchitis and emphysema. So that is what's depicted here. This is figure 62.2, which tells us that we start with tobacco, smoke, or air pollution. Which leads then to the inflammation of the airway epithelium, which then leads to infiltration of the inflammatory cells and release of the cytokines, neutrophils, macrophages, lymphocytes, leukotrienes, and interleukins. So once you get triggered with the tobacco smoke or air pollution, it sends off this cascade of inflammation of the airway epithelium. That leads to inflammatory cells and cytokines being released. That can cause those systemic effects over time, muscle weakness and weight loss. But it also can cause inhibition of the normal endogenous antiproteases, which has their effects here. And both, it also directly causes increased protease activity with breakdown of elastin and connective tissue of the lungs, and the continuous bronchial irritation and inflammation. Okay, so what we're saying here and talking about is that this chronic inflammation, airway obstruction, and air trapping is seen, okay? So the frequent and recurrent irritation of the epithelial cells and the subsequent response by the various leukocytes and these inflammatory mediators, the pathologic changes result in bronchial edema, and increased mucus secretion that would characterize the chronic bronchitis. And then also this other pathway that comes here that creates the continuous inflammation, inhibits the production then of those protease inhibitors, which have a protective role in maintaining our alveolar integrity. And so as a result of the inhibition, the protease enzymes break down elastin, resulting in the destruction of the alveolar walls that characterize the emphysema component. And a small percentage of the population is where this inherited alpha-1 antitrypsin deficiency is. Okay. So that's kind of the review when we talk about asthma versus COPD. Then they go into talking about the medications for asthma and COPD. Following along with your book, they talk about, then we have two main classes of drugs that we talk about: anti-inflammatory agents and the bronchodilators. Principal anti-inflammatory agents are glucocorticoids. The principal bronchodilators are beta-2 agonists. For chronic asthma and chronic COPD, glucocorticoids are administered on a fixed schedule by inhalation, typically. Beta-2 agonists may be administered for fixed schedule, long-term control, or as needed, the PRN to manage acute attacks. The beta-2 agonists are usually inhaled. So then the book goes through and talks about each of these classes a little bit with their prototype drug. First, it goes into talking about making sure we understand inhaled drugs and the importance of using those inhalers correctly. So the book starts talking about that most of these drugs are administered by inhalation. Okay, there are 3 advantages to inhaled drugs. So when you think about why do we need these drugs to be inhaled, it's for 3 advantages. 1, the therapeutic effects of the drug are directly delivered to the site of action within the lungs themselves. So because of that, number 2, systemic effects are minimized. And then number 3, because we're getting there right to the source, relief of acute attacks is rapid. So by inhalation, we can give that 3 ways: a metered dose inhaler, a dry powder inhaler, which is a DPI, and then the nebulizers. Okay. So a metered dose inhaler, they're small, they're handheld, they're pressurized devices that deliver a measured dose of the drug with each actuation. Usually people need 1 or 2 inhalations with the drugs. When it says to take with 2 inhalations of an MDI, you should have an interval of at least 1 minute to separate the first inhalation from the second inhalation. When you're using an MDI, you have to counsel the patient that they must begin to inhale before clicking the device and activating it. So you have to have a certain amount of coordination, right? They have to be able to hold the device, put it to their mouth, get their mouth around it, start to take their inhalation and click the button. So most people, when you're giving these medications, they need examples, they need training, they need to understand the appropriate way to do them, okay? So even with optimal use, only 10% of a drug, typically without a spacer, is going to reach and really work the right way and actually reach the lung. Okay. Spacers are the devices that attach directly to the MDI to increase delivery of the drug to the lungs and then decrease the amount of drug that's left in our oropharyngeal mucosa. There's several kinds of them out there. Some of them have a one-way valve, and some of them don't. Some spacers will actually sound an alarm like a whistling sound that will let you know that your inhalation was too rapid. So they've come up with a lot of nifty ways to do that. But on your image here, we can see that with a spacer, we actually get drug can reach the lungs versus 9% without the spacer. The next drug topic they talked about in your book was the dry powdered inhalers, which are called DPIs. Those tend to be more successful for patients. They're micronized powders. They also obviously are going directly to the lung, but they're breath activated. So that tells us that we don't have to have as much hand coordination to click the actuator in trying to do it at the proper time with your breath. So they're much easier to use. And when you compare them with the metered dose inhalers, the DPIs deliver more drugs than even that. And spacers are not used with the DPI. Then we have nebulizers. We all hopefully know what that is, with the small machine that converts the drug solution into the mist. And so the droplets in the mist are much finer than those by inhalers, resulting in less drug deposit on the oropharynx and increased delivery to the lungs. So inhalation of the nebulized mist is done through the face mask or through a mouthpiece held between the teeth. So because the mist produced by a nebulizer is inhaled with each breath, hand-breath coordination is also not a big deal. However, nebulizers take several minutes to deliver the same amount of drug contained in one inhalation from the inhaler, but for a lot of people, they feel like the nebulizers are more effective. Nebulizers typically are reserved for more hospitalization, but people do have them at home. But they're kind of cumbersome to like travel with and stuff. So most people routinely don't have their nebulizer, whereas the MDI is like you put that in your pocket. All right, when we get into the drugs that we talked about for the treatment of COPD and asthma, we're going to go through those and talk about them a little bit more. And like I said, we're going to review this from the Laney standpoint, and then we're also going to get on there and review them from the gold standard standpoint. So I'm going to create a slide here for you for glucocorticoids for some room for notes, okay? So our glucocorticoids are the most effective drugs available for long-term control of airway inflammation. So they can be used for asthma and for COPD. You can do them inhaled, you can do them orally, you can do them through the IV. There's generally considered that it's generally considered that the inhaled version has the least amount of adverse reactions. Obviously, we know that if we take systemic glucocorticoids, that's a whole new can of worms. When we use systemic glucocorticoids long-term, severe adverse effects are much more likely, right? Osteoporosis, decreased immune system, those kind of things that we've talked about. So we use the glucocorticoids for asthma and COPD because they reduce the respiratory symptoms and they suppress inflammation. So specifically, they decrease the synthesis and the release of the inflammatory mediators like those leukotrienes, the histamine, and the prostaglandins. So those are decreased both in how they're synthesized and the amount that are released, so you get direct reduction in inflammation. They decrease the infiltration and the activity of the inflammatory cells like the eosinophils and leukocytes, and then they decrease the edema of the airway mucosa secondary to a decrease in vascular permeability. So there's three ways that those steroids help. So you're decreasing the inflammatory mediators, decreasing the inflammatory cells, and decrease edema of the airway mucosa. How we use them can be for asthma or for COPD. They are good for asthma prophylaxis and for management of COPD exacerbations, but they don't alter the natural course of those conditions, even if we start them when people with asthma are children. But they provide significant long-term control and management of symptoms, so they're definitely at use, okay? So let's start with the inhaled glucocorticoids. They're very effective and they're much safer than the systemic glucocorticoids. They're the first-line therapy for management of the inflammatory component of asthma. Many patients with persistent asthma should use these drugs daily. And then they do have the use in COPD, primarily in exacerbations. Next, they talk about oral steroids. Those could be required for moderate to severe persistent asthma or asthma exacerbations, but remember that they have the risk of more adverse effects because of their systemic actions, and that those effects are worse the longer you're on it or the higher doses that you're on. Adverse effects for our steroids, remember, we're pretty much usually referring to the inhaled steroids. Most common adverse effects, as you probably know this from your nursing days, are the oropharyngeal candidiasis and dysphonia, which is hoarseness or speaking difficulty. Both of those are from the deposition of the inhaled steroids in the vocal cords or in the esophagus. To minimize those effects, patients should rinse their mouth with water and gargle after each and every use. That is a major point of administration. If you're prescribing an inhaled glucocorticoid, you should make sure that you're educating your patient on gargling after each use. They may need an antifungal if they actually do get the oropharyngeal candidiasis. With long-term high-dose inhaled glucocorticoid, there could be a degree of adrenal suppression, but it's typically not significant or not as significant as oral steroid use. Glucocorticoids can slow growth in adolescents and children, but they do not decrease the final adult height. So you can rest assured if you're starting a 16-year-old on an inhaled glucocorticoid for asthma. Long-term use of the inhaled can promote bone loss, but we know that the effect is much, much smaller and not to the same degree as with oral steroids. So remember, even for inhaled, though, we want to use the lowest dose that can control the symptoms for the lowest dose, and then making sure that they're doing their calcium and their vitamin D. And it's also an education point to make sure they understand they need to be active because they need to have weight-bearing exercises that help promote bone growth. They also give some patient education noted in your book about inhaled glucocorticoids, and they specifically say that you should educate your patient to inhale the short-acting beta agonist 5 minutes before inhaling the steroid. Remember that if someone is on oral or glucocorticoids, that if they get into a stressed environment like an acute illness, sometimes they're going to need increased doses of the steroids. There are 6 available glucocorticoids that are listed in your book. There's a nice table there that talks about which ones they are. Some of them are a dry powder inhaler, some of them are a metered dose inhaler. I do talk a bit about nebulized budesonide, which is Pulmicort. It was the first inhaled glucocorticoid, so it's the prototype that they speak of. Then the oral glucocorticoid typically is methylprednisolone or prednisone or prednisolone. Okay. The next drug your book goes to talk about is the leukotriene receptor antagonists, montelukast and zerzafirlukast are the ones there. So these are the LTRAs, and those are the drugs that suppress the effects of the leukotrienes, which are compounds that promote smooth muscle constriction, blood vessel impermeability, and the inflammatory response through direct action, as well as take part in the recruitment of the eosinophils and other inflammatory cells. So a leukotriene receptor antagonist is the drug that we can give that can help block this. The 3 drugs they do talk about here, Xylutin, zafirlukast, and montelukast, do work a little bit differently. Xylutin blocks the leukotriene synthesis. Zafirlukast and montelukast block leukotriene receptors. So they do work a little bit differently. Current guidelines, according to the book, state that they recommend using these agents as second-line therapy when an inhaled glucocorticoid cannot be used, and as an add-on therapy when your inhaled glucocorticoid alone is inadequate. They're generally well tolerated, but they could have the adverse effects of neuropsychiatric effects like depression or suicidal thinking, which is not a small one. The book talks specifically about Xyluten, which is Zyflo, which is again the inhibitor of the leukotriene synthesis. It's approved for asthma prophylaxis and maintenance therapy in adults and children 12 and older. Sometimes you can see the symptomatic improvement within 1 to 2 hours of dosing, but it is not considered a use for an abortive attack. It's not considered as an abortive if you're already having an attack. Xyluten can injure the liver, so you do have to watch liver enzymes. The zafirlukas is accolate, and so that is also used as a maintenance for chronic asthma in adults and children 5 and older. Again, it works a little different, is that it causes the reduced infiltration of the inflammatory cells, so you have less bronchoconstriction. It's administered orally. Can cause headache and GI disturbance. It goes on in your book to talk about a few patients have developed the Churg-Strauss syndrome, a potentially fatal disorder characterized by weight loss, flu-like symptoms, and pulmonary vasculitis, but that mostly happened if they were also on steroids and the steroids were withdrawn. You do have to watch for the liver function tests. I'd say in clinical practice, the one we see the most is montelukast, which is Singulair. It has 3 approved indications. So we're talking about montelukast, 3 approved indications: prophylaxis and maintenance of asthma, prevention of exercise-induced bronchospasm in patients of at least 15, and relief of allergic rhinitis. So it is not an abortive for asthma attack, because it works too slowly, but it is effective for prophylaxis and maintenance therapy of asthma. Although montelukast can be used for preventing exercise-induced bronchospasm, a short-acting beta agonist is still preferred. Important to know. The book also says that you have to monitor for the Churg-Strauss syndrome as well. The other thing that montelukast is unique is that it is the drug of choice that tends to be used more because it also has less drug interaction. Specifically, the book says that it does not affect the levels of theophylline or warfarin. The other one your book goes into talking about is cromolyn, cromolyn, cromolyn. It's an inhaled agent that suppresses the bronchial inflammation. However, the anti-inflammatory effects are less than the inhaled glucocorticoid, so it's not first-line treatment for asthma. It works by suppressing inflammation, but it does not cause bronchodilation. The drug acts in part by stabilizing the cytoplasmic membrane of mast cells, so they stabilize the mast cells, so they prevent the release of histamine and those other mediators down the line. So if we look at that in our previous thing here, it works here. So cromolyn works early in this process and helps suppress the mast cells so you don't get the specific mediators released like before. It's given via nebulizer, and it can be used in asthma as an alternative to the inhaled glucocorticoid. You will still see it. It comes up every now and again that I see in patients. These are patients that are usually managed by a pulmonologist. It also can be effective for prophylaxis of seasonal allergies and acute allergic prophylaxis before an allergen exposure. So some people do it like before mowing the lawn. If you're using it as a long-term agent, you can sometimes take weeks before you're going to see it. It can also be used for exercise-induced bronchospasm and allergic rhinitis, Intranasal cromolyn is nasal crom, and we talk about that in the next chapter as well. What I find interesting is the book does go on to say that cromolyn is the safest of all anti-asthma medications, which is interesting. All right, the other drugs we talk about when we talk about asthma and COPD is the monoclonal antibodies. These class of drugs show up, I swear, in every disease. There's a lot of indications for use for the monoclonals. There are 5 currently available that are listed there. None of them are approved right now as first-line agents, and so none are approved for acute asthma. The very most popular one, I would say, is the omalizumab, which is Xolair, Xolair. It was the first. Omalizumab is a monoclonal antibody that's unique because it's an antagonism of the antibody IgE. The drug is second line only for allergy-related asthma and only when your preferred options have failed. Although it does have some modest benefits, it does have the significant drawbacks. Number one, there's always a risk for an anaphylactic reaction to a monoclonal. And so it costs a lot and has to be given in a clinic type setting. When I worked in hematology oncology, we did have a couple of people, because I worked in a rural community, that came into the clinic to get their omalizumab for asthma, but we had to give it in the chemo clinic and monitor them. Omalizumab, if there's one thing to remember about it, it's unique because it works with the free IgE in the blood, and so it reduces the amount of IgE available to bind with the receptors on the mast cells. So it works very early in that process at the mast cell. Therefore, when it decreases that activation of the mast cells, it's decreasing the release then of the histamine, leukotrienes, and those other mediators that cause the bronchospasm in the first place. At recommended doses, the omalizumab actually decreases the free IgE in the blood by 96%. And even when treatment stops, it takes over a year before typically symptoms would resume. Okay, so the treatment is indicated with omalizumab for patient with moderate to severe asthma. Sub-Q injection, it does carry a black box warning because of the potential for anaphylaxis. There's little to no studies on omalizumab and the use in pregnancy, so we can't say for sure if it's safe or not. Then we have the interleukin 5 receptor antagonists, which are also part of the monoclonal antibodies. So the omalizumab here was the IgE one, and these two, benralizumab and mepolizumab and reslizumab, that's how I would say that, are those interleukin 5 receptor antagonists, often called IL-5. It's a selective cytokine that's responsible for the differentiation and maturation of eosinophils in the bone marrow. So by inhibiting interleukin 5, the IL-5 receptor antagonists decrease the production of the eosinophils. Because these drugs are targeted specifically towards the eosinophil, their approved use right now is for the treatment of severe eosinophilic asthma. They're not first line. The names for these are like Fasenra, Nucala, or Sinclair. This reslizumab, the Sinclair, has a black box warning as well for anaphylaxis. The dupilumab, which is Dupixent, is an interleukin 4 receptor alpha antagonist. So it's again a little different. IL-4 is an inflammatory cytokine. So many types of cells that express the IL-4 can include the eosinophils, the mast cells, the macrophages, etc. So dupilumab is a monoclonal Ig4 antibody. It's not a first-line drug, and it's restricted to patients with either eosinophilic asthma or dependence on oral steroids. So I wouldn't get too caught up in memorizing which one goes to which, but maybe in your book you have the chart of what follows under what category, etc., that you would know where to find it. But don't get caught up memorizing it, but be familiar with the idea that these are monoclonals. There's some differences, and know that in the chart somewhere those is where you can find those details that you may need. Okay, then the next one is the phosphodiesterase 4 inhibitors, which is roflumilast. My lord, people, roflumilast, which is daily Resp. I always call it by its trade name. That's not good practice for pharmacology. Roflumilast is approved for management of COPD. So severe chronic COPD with a primary chronic bronchitis component can be prescribed this. This works by on the CAMP cells, the cyclic adenosine monophosphate cells. So by raising levels of CAMP in lung cells, the drug reduces inflammation by suppressing cytokine release and by decreasing pulmonary infiltration by the neutrophils. So you get cough and excessive mucus production reduction, and mucociliary clearance is improved. So roflumilast is approved only for the management of COPD, and it's not a first-line treatment either. Okay, it does have the possibility of adverse effects to include diarrhea, lack of appetite, weight loss, nausea, headache, back pain, etc. All right, then we go into our bronchodilators. These are used to provide symptomatic relief in patients with both asthma and COPD. But again, if you're going to remember something about the bronchodilators, they do not alter the underlying inflammation. That's the part of the disease process. So that's why people who are on a bronchodilator also need inhaled glucocorticoid medications for long-term suppression of their inflammation. Monotherapy with a bronchodilator is appropriate only when asthma is very mild and the attacks are very infrequent. So the beta-2 adrenergic agonists, we've talked about this before. The inhaled beta-2 agonists are the most effective drugs we have for relieving acute bronchospasm and preventing exercise-induced bronchospasm. Okay, one more time. The beta-2 agonists are the most effective drugs available for relieving bronchospasm and preventing exercise-induced bronchospasm. Virtually all patients with asthma use beta-2 agonists as first-line drugs as a component of their asthma management regimen. Okay. There's a nice thing in your book that goes through the patient-centered care law across the lifespan for the beta-2 agonists. In pregnancy, they do note that the beta-2 agonist may cause uterine relaxation. So pregnant women must have adequate respiratory exchange to ensure adequate oxygenation of the developing fetus. Okay. How do they work? Beta-2 agonists are sympathomimetic. I hope that's coming back to you. So they're drugs that activate the beta-2 adrenergic receptors. So when we activate the beta-2 receptors in the smooth muscle of the lung, these drugs promote bronchodilation and thus relieve bronchospasm. So beta-2 agonists relieve bronchospasm, and they do that by activating the beta-2 receptors in the smooth muscle of the lung. That's how you get your bronchodilation and relieve your bronchospasm. The beta-2 agonists can be administered orally or by inhalation. Let me make you a slide here so you guys have some space. All of the oral agents that you use as beta-2 agonists are long-acting, but some of the inhaled agents are short-acting and then some can be long-acting. With short-acting inhalers, their effect begins almost immediately but peak within an hour and persist for 3 to 5 hours. Because of this, the short-acting beta-2 agonists, which is SABA, the SABAs can be used to abort an ongoing attack but cannot be used for prolonged prophylaxis. So if you took your short-acting beta-2 agonist inhaler in the morning and then exercise 4 hours later, that's not going to last long enough to actually prevent that. But we have the LABAs, which is your long-acting beta-2 agonists that last a lot longer. So those are drugs like formoterol and arformoterol. Their onset is relatively rapid, but then they last longer. So here's the point to remember. Inhaled SABAs, inhaled short-acting beta agonists, are taken PRN to abort an attack. In patients with exercise-induced bronchospasm, they're taken right before the exercise to prevent the attack from occurring. For hospitalized patients undergoing an asthma or COPD attack, a nebulized short-acting beta-2 agonist is the traditional treatment of choice. But they also know that in the outpatient setting, an MDI can be equally effective. So you have your short-acting and your long-acting beta-2 agonists. The short-acting are typically given PRN to abort an attack. If it's an exercise-induced bronchospasm patient, then they take it right before their exercise. The long-acting beta-2 agonists are for people who experience frequent attacks. Those are on a fixed schedule, not PRN. So long-acting beta-2 agonists are preferred over the short-acting for patients with stable COPD. Makes sense. However, in patients with asthma, the long-acting beta-2 agonists are not first-line therapy, and they must be combined with a glucocorticoid. Say that again. Long-acting beta-2 agonists can be first-line treatment for COPD, stable COPD. They are preferred over the SABA for stable COPD. But for asthma patients, LABA's first line must be combined with a glucocorticoid. Okay? And that is going back to part of this here, that the inhaled glucocorticoid helps take down this part here, and the long-acting beta agonist addresses this part here. So the treatment is both two-armed for asthma to address both of those. In fact, to use a long-acting beta-2 agonist as a monotherapy has been associated with an increase in death from asthma. So, LABA-glucocorticoid therapy is first-line recommendation for most asthma. The long-acting beta-2 agonists do carry a risk for asthma-related death because of that. We do have options again for the oral beta-2 agonist drugs. The onset is very slow though. Okay, for all the beta-2 agonist adverse effects, when they're inhaled and the short-acting, they're pretty well tolerated, but they can cause a tachycardia or tremor. For some people, we do worry about like chest pain or angina. For the long-acting inhaled beta-2 agonists, they tend to tolerate them very well, and especially because they're also taking the inhaled steroid at the same time. Oops. There's patient education noted in your book regarding the beta-2 adrenergic agonists that you can look at as well. The big thing is remember which drugs should be given fixed schedule, which drugs are given short-acting, which drugs have to be given in combination, and for what disease. The book then goes on to talk about for quick relief if someone's having an active attack. So to provide quick relief, the beta-2 agonist must be administered by inhalation. You're not going to get the quick relief by an oral formulation. So you can use a metered dose, the DPI, or the nebulizer. For drugs administered with a metered dose inhaler or the DPI, the initial dosing is scheduled 1 or 2 inhalations 3 to 4 times a day. When 2 inhalations are needed, they should be separated by 1 minute or longer, which tends to not always happen by patients that are feeling short of breath. They want them back to back. If you wait, what happens is you allow for the bronchodilation to occur so that the second inhale can penetrate even further and you get more bang for your buck. There are 3 single-agent inhaled long-acting beta-2 agonists that are approved for treatment: salmeterol, formoterol, and arformoterol, which is Ceravent, Floridil, and Brovana. So be very careful when you're looking at trade names for these drugs. We should really use the generic name so that you can tell if it's combined with something or not. You dose your long-actings every 12 hours. You can use your short-acting in between. There are 2 oral preparations that can be used for long-term control, and that is albuterol and terbutaline, and that is approved for long-term use of asthma patients. There's a great part of your book that is the summary of the key prescribing considerations that you could refer to as well, that has that pretty well written down. All right, the next kind of drug that they talk a lot about in here, in your book anyway, is the methylxanthines, which is theophylline, or even technically caffeine. But let's talk briefly about theophylline. Theophylline is the principal drug that could be used in asthma if you're going to use a methylxanthine. They work directly to cause bronchodilation, has a very narrow therapeutic range, so you have to dose it very carefully. It works by producing bronchodilation by relaxing smooth muscles of the bronchi. And although the mechanism is not clearly understood, it's probably because of the blockade of the receptors for the adenosine. So you use oral theophylline for maintenance therapy of chronic and stable asthma. It is less effective than the beta-2 agonist, but it has a longer duration of action. So with regular use, theophylline can decrease the frequency and severity of asthma attacks. Because its effects are prolonged, theophylline may be most appropriate for patients who experience nocturnal attacks. But remember, it has that narrow therapeutic window, and so you have to dose it very carefully, and people have to understand how to take it and what the side effects are and those things. It used to be everybody was on theophylline if you had COPD, but it's no longer routinely recommended. This is probably a drug that's only going to be given in a pulmonology kind of environment. The big thing about theophylline to remember is that it's oral, it's for COPD, it has a narrow therapeutic window, and so you have to be careful educating your patients about it. And they also can't really drink a lot of beverages or take anything with a lot of caffeine, because it actually kind of deactivates the theophylline, and they have to know that it's a narrow therapeutic window. So if they get the symptoms, nausea, vomiting, diarrhea, abdominal pain, they need to be seen. And they have to stop smoking marijuana or tobacco. Please note in your book, there is a section that talks about the treatment for overdose or toxic levels of theophylline, one of them which is to stop the drug, and that you can actually administer activated charcoal with a cathartic in the event of an overdose. So there is an option for treatment for that. Again, got to be careful with smoking, got to be careful with taking caffeine. So as you can see, we have a lot of other drug options that are easier to take than the oral theophylline, but it is a drug that's still around, and you may see questions on it in board and board tests. There's other methylxanthine type drugs, one of which is the aminophylline, but I'm not going to spend a lot of time talking about that. It's basically theophylline is the drug I want you guys to understand and know how that works. Then we have our anticholinergic drugs, okay? So if you had to know the difference between like a beta-2 agonist and then the anticholinergic, understanding that they work very differently, but they're both kind of mainstays of treatments. So our beta-2 agonists are the ones that are causing that smooth muscle relaxation and bronchodilation. The anticholinergic drugs improve lung function because they block the muscarinic receptors in the bronchi and then can reduce bronchoconstriction. So these drugs, the anticholinergics, have FDA approval for COPD, but there's more and more literature out there that they should be supported with asthma as well. So they're all inhaled, typically drugs, so they typically are well tolerated. The first drug that was ever done in this class was the ipratropium. But then we also have 3 long-acting anticholinergic drugs, the aclidinium, iotropium, and the umeclidinium. Sheesh. Okay, ipratropium, which is Atrovent, is an atropine derivative, which is administered again by inhalation with the purpose of relieving your bronchospasm. It's again approved for COPD, but it's being shown to be effective off-label in asthma. But for us and our purposes, let's use it as COPD, anticholinergic. It's similar to atropine. Ipratropium is a muscarinic antagonist, so by blocking the muscarinic cholinergic receptors in the bronchi, ipratropium prevents bronchoconstriction. It's very fast acting. Within 30 seconds, the therapeutic effects start, and they can last for 6 hours. Ipratropium is effective against allergen-induced asthma and exercise-induced bronchospasm, but it's not as effective as our beta-2 agonists. We typically use them together. So why do we use an anticholinergic and a beta-2 agonist? Because they work differently and their beneficial effects are additive, so they work really well together. Possible adverse effects of our anticholinergics tend to be pretty minimal. Most common is dry mouth or some irritation of the throat. If systemic absorption is sufficient, when the drugs can raise intraocular pressure in patients with glaucoma. Adverse cardiovascular events like heart attack and stroke have occurred in people taking the ipratropium, but because typically absorption is minimal, it seems unlikely that ipratropium was the cause. So they don't really have a lot of negative side effects associated with them. Tiotropium, which is Spiriva or Spiriva Respimat, is a long-acting muscarinic antagonist approved for maintenance therapy of bronchospasm associated with COPD. Like ipratropium, tiotropium relieves bronchospasm by blocking muscarinic receptors in the lungs. The therapeutic effects begin pretty quickly, like within 30 seconds, and they can last up to 24 hours. With each subsequent dose, and as you're taking them regularly, the bronchodilation gets better and better until about 8 days, when you then plateau. Compared with ipratropium, tiotropium is more effective and its dosing schedule is more convenient because tiotropium is once a day and ipratropium is 4 times a day. So if you are trying to relieve an ongoing bronchospasm, you use your short-acting beta-2 agonists typically, still because they're more effective. Most common side effect for tiotropium is the dry mouth. People sometimes need to chew on gum or have saliva substitutes. The aclidinium, which is Tudorza Pressair, is another long-acting muscarinic agonist, which is again with bronchospasm and COPD. It is only for maintenance therapy. Can cause a headache, nasopharyngitis, and a cough. Umeclidinium is Incruz ellipta. I hear that a lot. I hardly call it umeclidinium, which I should, but I don't. We call it the Incruz ellipta. It's the newest and latest and greatest long-acting muscarinic agonist, and it's indicated for bronchospasm associated with COPD. In addition to its being a single agent, it also can be combined with the long-acting beta-2 agonist, and we call that the Anora ellipta. So both the single and combination drugs can be used for COPD maintenance. The interesting thing about umeclidinium is that it contains lactose as a part of the powder mix. So in theory, people who have hypersensitivity to milk or milk protein allergies probably should not take the umeclidinium. One of the tricky things about COPD management and asthma management is we have all these drugs, then we have nicknames for the drugs like LAMA, SAMA, SABA, LABA, whatever, and then we have combination drugs. So it's really important that you're paying attention on test questions or different things like that, that you're really actually looking at what the drug is and identifying if it's short-acting, long-acting, etc. Okay? So your book goes through and talks about some of those tables or some of those drugs. It's table 62.7 that has a list of some of them as well, which is kind of nice. What I want you to know is that we can combine a beta-2 agonist and an anticholinergic together for ease for the patient. And we know that the effects together are additive and they work really well together. So for example, the beta-2 agonist again promotes bronchodilation by stimulating the adrenergic receptors, which relaxes the smooth muscle of the lung. Whereas the cholinergic antagonists or the anticholinergic drugs promote bronchodilation by blocking the cholinergic receptors. And that causes the relaxation of smooth muscle tone by preventing stimulation of the cholinergic receptors. So, beta-2 agonists also work in the bronchioles, whereas the anticholinergics work in the bronchi. So they work in different areas in different ways, so they're very good together. They are all inhaled. All right, so those are kind of the drugs in and of themselves. What gets kind of tricky is keeping up with current guidelines, especially for the purposes of testing and those things. So your book was published, Laney's was published in 2021. We do know that there's probably newer up-to-date information, so I'd like to go over some of that with you. I do agree with Laney that they say before we really get into treatment and understanding that, it's important that we discuss PFTs, pulmonary function tests. So I'm going to add a slide here, and you really have to kind of understand that, because when we go into the algorithms of how you treat these diseases and kind of the stepwise approach, there's a lot of abbreviations for PFTs that are in here. One of the most important ones you're going to see is the FEV1. Your book actually goes on to say it's the single most important test of lung function. So to determine the FEV1, the patient inhales completely and then exhales as completely and as forcefully as possible into the spirometer. The spirometer then is measuring how much air was expelled during the first 1 second of exhalation. So it's the forced expiratory volume 1, FEV1, in 1 second. The results are then compared with a predictive normal value that they calculate based on your age, sex, height, and weight. So if you have obstructive pulmonary disease, the amount of air that you are forcibly going to be able to exhale in 1 second will be decreased. So you should have a decreased FEV1 if you have obstructive COPD. Then we have the FVC1, is the total volume of air that the patient can exhale after a full inhalation. So then they put those two together, and then you get the FEV1 FVC ratio, which is given as a percentage. So that's the vital capacity exhaled during the first second of forced expiration. So we use the ratio of FEV1 and FVC, the forced vital capacity. We use that ratio to distinguish whether or not it's an obstructive or a restrictive cause to their disease. So obstructive, like COPD, chronic obstructive pulmonary disease, prevent adequate exhalation. You can't get all of it out. And since FEV1 measures forced exhalation, the FEV1 is decreased in COPD. So also the FEV1/FVC ratio will be decreased. Restrictive conditions of the lungs are those that prevent adequate inhalation. So this is things such as pulmonary fibrosis or myasthenia gravis or some of the skeletal muscular conformities or trauma or something that prevents you getting the air in and being able to expand your lung. So if it's a restrictive condition, the FVC is usually decreased. So the FVC is usually decreased, so the ratio is normal or even increased. So if you have an obstructive lung pattern, you should have a decreased FEV1 and a decreased FEV1 FVC. The PEF is this the peak expiratory flow, which is the peak flow meter, the handheld device that we give patients, especially with asthma. The results should be fairly approximately equal to the FEV1. So although FEV1 is much more accurate, the measures correlate well. So we use that outpatient with patients that they can monitor their own peak flow, typically in the mornings, so they can know if their peak flow is starting off poorly, they need to manage their symptoms better for the day. Okay, so we talk about these things because when you go into your algorithms of how you're going to treat these diseases, you have to understand what these mean. both asthma and COPD, first of all, you have to figure out how you're going to classify what stage the patient's in based on the amount of symptoms they have, if they're nocturnal symptoms, how many hospitalizations they have, how many times they have to use their rescue inhaler. All of those things are what need to be known to quantify asthma, for example. And then especially for COPD, how many hospitalizations, how many times they've had to do those things are also in there. So table 62.1 in your book is very helpful because it walks through the steps for managing asthma. Okay, so if you study in your book, it's going to describe the different steps. And it helps you determine whether you're trying to treat an acute attack or not, or those kind of things. Table 62.9 is the clarification of the asthma severity and the recommendations for initial treatment. So for your studies, reviews table 62.9, review table 6210 would be good as well, and then table 6211. Between those two things, you should probably be able to answer questions about how you manage the asthma. I would not concern yourself on memorizing them from pure rote memory, these steps. Walk through, read through, feel comfortable, kind of what the differences are, remember what you're looking for. So in a core of a question, you recognize, oh, if it's nocturnal or not nocturnal, is it how many times they use their rescue inhaler or not, how long they've had it or not, hospitalizations or not, have they been on steroids or not. Those are the things that you need to know to cue in on. And then you can refer to your tables in your questions so long as you can find them quickly in your book. So highlight them or know where they are for these chapters so that you can figure out how to treat asthma based on what step they're in and what the algorithm says to do. Okay. Beyond that, especially since we're in an acute care program, when we talk about severe acute exacerbations, your book does go in there into detail in that. So remember, if you're in an acute severe asthma exacerbation, we have a couple of different goals. Number one is to relieve the airway obstruction, relieve the hypoxemia, and then really normalize our lung function as quickly as possible. So we have a couple goals: relieve the obstruction, relieve the hypoxemia, and return the lungs to functioning well. So we give oxygen if needed. We give a systemic glucocorticoid to reduce airway inflammation, IV or PO. Then we give a nebulized higher dose, SABA, short-acting beta-2 agonist, to relieve obstruction. And then we give a nebulized ipratropium to further reduce airflow obstruction. Okay. So if you were to be asked, how do you treat a severe asthma exacerbation? It's oxygen when needed, systemic steroid, high-dose SABA, and ipratropium. Oftentimes after resolution of the crisis, but if it really was a true crisis, then people typically take an oral steroid for 5 to 10 days afterwards, and also a medium dose inhaled glucocorticoid, and understand that it could take weeks for the lung function to return to normal. So you have your steps on how to treat different levels of asthma in the outpatient setting, but when you are treating severe exacerbations in the ER or the inpatient setting, you have those goals to think about what you're trying to achieve. So one, you're trying to reduce the hypoxemia with oxygen if needed. You're giving an oral or IV, a systemic steroid. You're giving a SABA, high dose, nebulizer typically, and then you're giving a nebulized ipratropium. So you're giving a beta-2 agonist, high dose, short acting. You're also giving the short-acting SAMA, okay? Remember, I have said before in different topics that we don't just prescribe drugs, we also prescribe and educate on interventions. So for asthma, also think about the things for teaching and coaching for your patient. And those are things like try to avoid their allergen triggers. So if they know that they're allergic to cats, if they know that smoke sets them off, maybe you're not going to go to someone's house who smokes. If you go into a 200-year-old farmhouse and you start coughing and sneezing, you may be having some exposure to mold or some of those other toxins, or dust mites, or sometimes cockroaches in their feces, and those things are things that can trigger people. So just as much as you educate, just as much as you prescribe medications, it's also important to prescribe interventions with education to avoid, the prescription is avoid wood smoke, avoid dust mites, avoid, your allergen that you know to be a trigger for your asthma. Okay. We're going to kind of stop here and jump ship in a new lecture where we're going to go over the GOLD, which is the Global Initiative for Obstructive Lung Disease, updated. Okay.